Extrapulmonary tuberculosis, an old but resurgent problem. Abstract. Tuberculosis, TB, primarily affects the lungs, but some of its most devastating clinical consequences arise because of its ability to spread from the lungs to other organs. Extrapulmonary TB, EPTB, constitutes 1,520% of all TB, tuberculosis, cases. Imaging findings are not always specific and can mimic many diseases. Therefore, EPTB, extrapulmonary TB, should be considered in the differential diagnosis. Particularly in patients with immune system disorders, AIDS, acquired immunodeficiency syndrome, patients receiving chemotherapy, etc., and those in other high-risk groups including people with diabetes. The bacterium's passage to the regional lymph nodes is essential for developing a protective T-cell-mediated immune response. But the bacterium can spread hematologically and via the lymphatic system, leading to extrapulmonary involvement. Diagnosis of EPTB, extrapulmonary TB, in high-risk patients is made based on suspected clinical and radiological findings. But further positive culture and histopathological confirmation may be required in some instances. Radiological evaluations are critical for diagnosis and crucial in planning the treatment and follow-up. This paper aims to review the typical and atypical imaging features and the differential diagnosis of EPTB. Keywords: tuberculosis, extrapulmonary tuberculosis, magnetic resonance imaging, computed tomography, X-ray. Key points: EPTB is not an uncommon type of TB, but it is difficult to recognize. EPTB usually occurs with the lymphohematogenous spread of primary infection, during or later, to extrapulmonary organs but can sometimes develop without pulmonary involvement. Radiological evaluations are critical for diagnosis and follow-up. Background: tuberculosis, TB, is one of the infectious diseases with the highest preventable morbidity and mortality rates globally. According to the World Health Organization, Global TB Report 2021, an estimated 10 million people fall ill with TB, and 1.5 million die from TB every year. High-risk groups include immunosuppressed individuals, malnourished people, people of low socioeconomic status, prisoners, alcoholics, children, the elderly, the homeless, nursing home residents, those living in TB endemic areas, and healthcare workers. 1 in every 5 TB cases presents with extrapulmonary TB, EPTB. The tuberculin skin test, serum interferon gamma release, polymerase chain reaction, adenosine deaminase assays, and imaging modalities are used to diagnose EPTB. Although biopsies and culture studies remain the gold standard, EPTB can occur almost anywhere in the body, most commonly in the lymph nodes, 50%, the pleura, 18%, the genitourinary system, 13%, bones and joints, 6%, the gastrointestinal system, 6%, the central nervous system, CNS, 3%, and the spine, 3%. EPTB shows various clinical and radiological features depending on the organ it affects, which can often mimic other diseases. Therefore, early diagnosis and treatment are essential. Radiological modalities can be used separately or together, depending on the affected organ and the extent of the involvement. For example, X-rays and computed tomography, CORT, are conducted if there is bone involvement, ultrasound, US. CORT, computed tomography, and magnetic resonance imaging, EMRI, in cases of possible abdominal TB. This in the presence of a superficial lesion such as lymphadenitis, mammography. And this if mastitis has developed, and EMRI, magnetic resonance imaging, if the CNS, central nervous system, is affected. EMRI helps show whether deep tissues are affected by TB in the presence of musculoskeletal involvement. Additionally, positron emission tomography, PET, CORT, computed tomography, can evaluate the extent of skeletal TB and monitor the response to treatment. This review emphasizes radiology's role in diagnosing EPTB by presenting examples of TB that involve different parts of the body. Pathophysiology. TB is a chronic bacterial infection caused by mycobacteria called the Mycobacterium tuberculosis complex, Mycobacterium africanum, Mycobacterium microti, Mycobacterium tuberculosis, and Mycobacterium bovis. It is characterized by the presence of caseous granulomas in infected tissues. Tuberculosis is the cause of the disease in 9,799% of cases. TB is an aerobic, acid-fast, non-motile, non-encapsulated, non-spore bacillus discovered by Robert Koch in 1882. It can involve almost all organs but is most frequently found, 8,085%, in the lungs. The cell wall structure of mycobacteria is different from other bacteria. They have an intracellular lifestyle and chronic infection properties and are resistant to chemical structures including acid and alkaline environments, antibiotics, disinfectants, enzymes, and free radicals. The cell structure prevents phagolysosomal fusion formation within the macrophage, which plays a role in immunity. The disease is most commonly transmitted by entering tuberculosis into the lungs via droplets from person to person or transferring bovis into the gastrointestinal tract by consuming non-pasteurized dairy products. Although rare, cases involving congenital transmission, sexual transmission, vaccination, and therapeutic instillation have also been reported. The TB bacillus spreads to the lung alveoli via droplets, phagocytoses by alveolar macrophages, and multiplies within macrophages. Alveolar macrophages differentiate from macrophages to histiocytes by interacting with T lymphocytes. Epithelioid histiocytes and lymphocytes gather in small clusters and form granulomas to restrict the disease. Tis granuloma, with a central area of caseous necrosis, containing bacteria, is called primary lesion or Ghosn focus. If this granuloma breaks up, aerosols are formed that can infect other people via expectoration. Bacillus growth in macrophages and alveolar spaces are followed by new monocyte migration from the blood to the lesion area and the migration of macrophage-mediated bacilli to neighboring lymph nodes. The bacilli can then spread from lymph nodes to the subclavian vein and throughout the body via the hematogenous route. Using the lymphohematogenous route, the bacillus creates new infection foci until an immune response is triggered. Different organ involvements occur. Extrapulmonary involvement may present with or without pulmonary infection, and EPTB can affect any organ or tissue except for the hair, nails, and teeth. The pathogenic life cycle and extrapulmonary spread of tuberculosis are summarized in Fig. 1. Involvement of the body systems. Nervous system. CNS involvement has been found in 510% of patients with TB and 20% of those with AIDS-related TB. It is one of the most significant causes of morbidity and mortality in TB endemic areas. CNS TB is usually caused by hematogenous spread, often directly from an intracranial or extracranial focus. Clinical features are variable. However, a nonspecific headache, neck stiffness, fever, vomiting, radiculopathy, and even coma can appear in most cases. The clinical and radiological manifestations of CNS TB can mimic many inflammatory, infectious, and tumoral diseases. Cranial involvement of TB may present as extraaxial, tuberculous leptomeningitis and tuberculous pachymeningitis, intraaxial, tuberculoma, focal cerebritis, tuberculous abscess. tuberculous rhombencephalitis or tuberculous encephalopathy, tuberculous leptomeningitis. Leptomeningitis is the most common CNS TB finding in children and adolescents and develops due to the hematogenous spread of M. Tuberculosis. The presence of exudate, which develops in the subarachnoid space at the base of the brain, is specific to tuberculous leptomeningitis and can be seen with CORT and contrast-enhanced MRI in particular, Fig. 2. The most common location is the interpeduncular fossa. In the differential diagnosis, infective meningitis and inflammatory diseases such as rheumatoid arthritis, sarcoidosis, and carcinomatous meningitis should also be considered. Possible complications of tuberculous leptomeningitis include progressive hydrocephalus, vasculitis, infarction, and cranial neuropathies. The most common complication is communicating hydrocephalus, which is caused by the obstruction of cerebrospinal fluid into the basal cisternae. In some cases, non-communicating hydrocephalus caused by a tuberculoma or tuberculous abscess may also be seen. Ischemic infarction may also develop as a result of cerebral arteritis. Hemorrhagic infarction caused by dural venous sinus thrombosis is another complication of tuberculous leptomeningitis. Cranial nerves 2, 3, 4, and the 7th may be affected by vascular ischemia or nerve entrapment, and the diagnosis is made with nerve thickening and enhancement in MRI. Tuberculous abscess. Tuberculous abscesses are rarely seen. A tuberculous abscess is either solitary or multiple lesions and is usually multiloculated with liquefaction necrosis in the central area. CORT and MRI are visualized as a mass with a cystic center, surrounding edema, and a contrast-enhanced wall. A tuberculous abscess is different from a tuberculoma, which presents with caseous necrosis and liquefaction in the center. Tuberculoma. The center of a tuberculoma contains necrotic caseous material surrounded by a capsule comprising fibroblasts, epithelioid cells, Langerhans giant cells, and lymphocytes. Lesions may be solitary, multiple, or miliary, and the frontal and parietal lobes are often involved. Ring-like enhancement is observed on CORT, and the typical finding of a tuberculoma is a central nidus of calcification with surrounding ring-like enhancement, known as the target sign. The MRI appearance of tuberculomas varies depending on whether or not there is caseation. Non-caseating tuberculomas are solid lesions that are non-necrotic, are located in subcortical white matter, are hypointense on T1 weighted images. Hyperintense on T2 weighted images, show post-contrast homogeneous enhancement, and are surrounded by vasogenic edema. Caseating tuberculomas are seen in two forms as solid caseating tuberculomas, early stage, and tuberculomas with central liquefaction, late stage. Solid caseating tuberculomas appear hypointense or isointense on T1 weighted images and hypointense on T2 weighted images caused by paramagnetic radicals that develop due to the inflammation and the capsule being stained in the form of a ring in contrast-enhanced sections, Figs. 3, 4c. In contrast, the tuberculomas with central liquefaction present centrally hyperintense signal and peripheral hypointense rim, capsule, on T2 weighted images, Fig. 4b. Neurocystosarcosis, fungal granulomas, pyogenic abscesses, tumors such as lymphomas, gliomas, and metastasis are included in the differential diagnosis of tuberculomas. Spinal cord TB. Spinal cord TB can be observed in cases of intramedullary myelitis, spinal meningitis, and arachnoiditis. It develops because of the direct spread of tuberculous spondylitis from the vicinity or hematogenous spread from the primary focus. Spinal edema and segmental infarcts may develop due to infective thrombosis and vasculitis in the spinal arteries. An increase in cord signal is observed in T2-weighted MRI images caused by thick, irregular meningeal involvement, Fig. 5. Spinal cord and root inflammation, myelitis, Fig. 6. Edema and infarction. Syringomyelia caused by chronic arachnoiditis can also be detected in the later stages. Extreme rarely, only 2 out of 1,000 cases of central nervous system TB. It may present as intramedullary spinal tuberculoma, Fig. 7. Other spinal cord lesions, for example, myelitis, astrocytic glioma, ependymocytoma, and hemangioblastoma, should be considered in the differential diagnosis. Head and neck. Tuberculosis of the larynx. Laryngeal TB develops in 1 out of every 100 cases with lung TB, and almost all cases with laryngeal TB have primary lung TB. This result is explained by the direct contact of bronchogenic secretions with the laryngeal mucosa. Rarely, laryngeal tuberculosis may develop without pulmonary involvement. In a patient with pulmonary TB, the lesion in the larynx should first suggest laryngeal TB. Its symptoms are hoarseness, pain, and odynophagia. Vocal folds, pre-epiglottic and paraglottic areas show soft tissue thickening and inflammatory changes, Fig. 8. Tuberculous lymphadenitis. Tuberculous cervical lymphadenitis is also known as scrofula and is the most common form of EPTB seen in endemic populations. Cervical lymphadenitis may develop during primary lung infection or via lymphatic dissemination from the mediastinal lymph nodes after the latent period. Although lymph nodes initially appear homogeneous, Figs. 9, 10, they may later be observed as nodular formations that show low cord density due to central necrosis. Calcification can also be seen in lymph nodes in the later stages. Ultrasound findings are variable. While the first finding is a round-shaped nodal enlargement in the early stage, abscess, necrosis, and fistula formation are more common in the late period, Fig. 11. Localizations of tuberculous lymphadenitis include cervical, 63%, mediastinal, 27%, and axillary, 8–10% nodes. Most cases present with unilateral cervical lymphadenopathy. The differential diagnosis considers the metastatic necrotic lymph nodes of papillary thyroid carcinoma and squamous cell cancer. Other regions. The areas less frequently involved in the head and neck region include the temporal bone, pharynx, tonsil, sinonasal cavity, thyroid gland, skull base, lacrimal sac, bulbus oculi, and other regions of the neck. Primary involvement is infrequent. It usually develops as a result of hematogenous dissemination, e.g., thyroid, after the lung infection, contact with the infected sputum, or saliva, e.g., eye globe, or through the ingestion of unpasteurized milk, e.g., tonsil, pharynx. It is generally observed as nonspecific inflammatory soft tissue thickening, Figs. 12, 13, and abscess, Figs. 14, 15. In advanced cases, soft tissue masses and bone erosions can also be detected. In tuberculous otomastoiditis, increased soft tissue density is observed in the tympanic cavity on cort in the early stages, while destruction in the middle ear structures and retroauricular, epidural abscesses can be seen in the later stages. The differential diagnosis includes pyogenic or fungal infection, sarcoidosis, cholesteatoma, and Wegener's granulomatosis. Chorioretinitis and uveitis are common in ocular TB. Imaging findings show a unilateral choroidal mass, with melanoma, metastasis, hemangioma, sarcoidosis, and systemic mycosis considered in the differential diagnosis. Mediastinum. Mediastinal lymphadenitis is more common in children with TB than in adults. Tuberculous lymphadenitis is usually observed unilaterally in the right hilar and paratracheal area. In court, necrotic lymph nodes larger than 2 cm indicate the presence of active disease. Fig. 16. Calcified lymph nodes and Ghosn focus form the rank complex. Pleural effusions or empyema can be seen in cases of TB. Fig. 17, and tuberculous empyema can sometimes mimic a thoracic wall mass. Fig. 18. Cardiac TB is very rare, only 0.5% of cases of extrapulmonary tuberculosis, although pericardial involvement is seen more frequently than myocardial involvement. Involvement of the heart by TB can appear by hematogenous seeding from infected lung, direct spread from the adjacent focus, or via a lymphatic feed from mediastinal lymph nodes. In tuberculous pericarditis, pericardial thickening, greater than 3 mm, irregular contours, and mediastinal lymphadenopathy are observed. An inferior vena cava diameter of greater than 3 cm, bilateral pleural refusion, intraventricular septum deformities, pericardial refusion, and localized pericardial calcification can also be observed. Fig. 19. Myocardial involvement is asymptomatic but can be detected postmortem. Breast TB is a rare form of EPTB that affects multiparous and lactating women between 20 and 40 years old. While the spread of infection causes the primary form through abrasions in the skin of the breast or through cracks in the nipple, the secondary form can be caused by retrograde spread from infected axillary lymph nodes or by direct spread from adjacent tissue. The patient's general condition is good, and systemic findings are not generally observed. The clinical presentation is nonspecific and variable, so it is difficult to distinguish clinically between granulomatous mastitis and breast cancer. However, in most cases, a painless palpable mass is often found in the breast's upper outer quadrant or central area. Breast tuberculosis is radiologically observed in 3 forms: nodular, diffuse, and sclerosing. Because females of reproductive age are affected, this is usually the first-choice imaging modality. The disease may present as a circumscribed or indistinct mass. Additional findings such as abscesses, fistulas, sinus tracts, increased skin thickness, retraction can be observed, but suspicious calcifications are not generally expected. Fig. 20. MRI can show the extension of an abscess into extramammary areas and can also show the fistula tract's continuation into deep tissues. Fig. 21, 22. Histologically, breast TB is a form of granulomatous inflammation, so it is not easy to diagnose it pathologically. A core needle biopsy generally supports the diagnosis. Diagnosing breast TB has 3 essential pillars: clinical examination, radiological evaluation, and histopathological sampling.